Good afternoon to you all, and thank you very much for giving me the opportunity to discuss with us about the guidelines used. You know that one of the most important challenges today for our specialty is the overuse of imaging, and this is mostly related to the poor use of guidelines, not only in Europe but also in the rest of the world. And I would like just to mention one of the conclusions of this paper published in the Lancet in 2017. And they said, they concluded that an overuse of healthcare services coexist within population, within systems, and even within patients around the world. And that this phenomenon affects not only developed but also developing countries. And of course, the overuse is going beyond imaging, as you can see here. For example, the rate of inappropriate total knee replacements is 26% in Spain and 34% in the US. And if you look here at the use of percutaneous coronary intervention, there is a ninefold variation in use. And so there are many examples for that. We are going beyond imaging, and imaging, of course, is also affected. So this is an European-wide data in which are displayed the number of examinations per thousand of population, and this red line represents the mean value. And you can see that some countries are under this mean value, meaning that they're in a situation of underuse for some reason, but many other countries are in the situation to be in an overuse. And more recently, the study was published in Spain, and they analyzed the appropriate use of medical imaging in 2 Spanish public hospitals, and they showed that 45% of examinations were not appropriate. And again, in this study made in the emergency department in the US, they showed that between 1996 and 2007, the visits increased by only 11%, but at the same time, the CT increased by more than 300%. And this article published in Radiology recently showed a very strong heterogeneity of CT and MRI utilization across the country. And you know that in this country, it is generally accepted that 30%, 1/3 of tests are inappropriate. Therefore, the point is that there is an evidence of imaging overuse and that it is a worldwide phenomenon. What are guidelines? Guidelines, they are established for a better use of medical services in large and at large, but of course of imaging. They are supposed to be evidence-based, but in fact they are mostly expert opinion. They started in the 1980s, so it's a relatively young phenomenon, and the guidelines were mostly established by professional organizations. The principles of guidelines are listed here. They're very simple. Clinical effectiveness. The guidelines propose the most effective examination. The dose exposure, they propose the lowest. And cost effectiveness guidelines, they choose the cheaper one. And in addition, there is some elements of what is considered as a good referral. Has the test already been done? Is the necessary information provided? What is the right test? And is imaging needed? I will come back on that further. So what is the current situation in Europe? The current situation is not very good because you know that there is a regulation which makes the availability of guidelines, which is an obligation for member states. And in 2014, we made a survey in which we showed that guidelines were available in only 70% of countries, and that in fact only 2 countries truly established guidelines, UK and France. And even when guidelines were available, we have showed that they are not used For example, in Belgium, they said we have referral guidelines. In fact, nobody really takes them into account. And it is the same in Hungary, Netherlands, Spain, Italy, Ireland, Germany, even in France, where we established guidelines. I remember was chair of the French Society at this moment, and the Ministry of Health told us, "I'm sorry, guidelines are very interesting, but we don't have the means to disseminate them to all the practitioners in France." So this experience shows that regulation alone is not effective for guideline utilization. In fact, the guidelines have some limitations. There are 6, 7 maybe reasons, and I have highlighted in here of the most important limitations. They are generic, rigid, because they are population-based and not patient-centric at all. They are not integrated into the workflow and not at the point of care. They are like books or even computer or even application, but not really integrated into the workflow. And last but not the least, they are not supported by a global policy in general. So we have to change paradigm and to move from producing guidelines. There are guidelines which are available for free, and to using guidelines, how to improve the use of guidelines. And because they are integrated in the workflow, and because they are patient-centric, clinical decision support systems are expected to be efficient. What are the advantages of the CDS? For a good referral, for example, the CDS can check for prior exams for the same patient. CDS requires referrers to submit a clear reason for the exam. CDS provides feedback on the appropriateness of different modalities for a clinical indication. And finally, CDS provides feedback whether imaging is the best answer. In addition, there are other advantages. CDS provides an access to guidelines, and they are adaptable and scalable. I will show you some examples. First of all, how it works. This is very simple. Even the CDS itself is complicated. It's very simple. First, you select the test. Here is the CT of the head. The reason for the examination is ataxia, and the feedback is very, very, very fast. And for example, here the CDS said CT is okay, but it's only yellow. The best examination, which is the green one, would be MR. And here for this examination, then the request on MR imaging of the lumbar spine with a chronic symptom of back pain. And you know that in advance that the CDS says lumbar spine MRI has low utility, and X-ray and CT as well. And the physician, in fact, he has the choice either to proceed, to cancel, or to change. It is interesting to see here in this publication that where examinations are considered as inappropriate by the system, by the CDS, 63% of these examinations are being done. Why? Just because there is an opinion of medical necessity, but without any specification. This example is very interesting because it shows that the CDS is not a machine doing the job. It's a guidance tool which allows the physician to make a final choice. But it is also an educational tool because it provides an access to the key paper supporting the CDS conclusion. This example in the Mass General, maybe this is the place in the world where the CDS is the most widely used. And you can see here the implementation of the CDS in the hospital. And when the CDS is largely implemented, there is a significant drop of the volume of a CT examination. And here, this example is also very interesting, published in a study in the emergency department. And you can see here that they started by implementing CDS for CT angiography of patients with suspected pulmonary embolism, then followed by CDS for lumbar spine MRI of patients with low back pain, And here, for CDS, head of CT patient with mild traumatic brain injury, and implementing of CDS tracking duplicate studies. And you can see that the net effect is that there is a significant reduction of the volume examination. And it shows also that you could have a scalable approach. You could start, for example, with the emergency department and to target pulmonary embolism as I did. I think it is very interesting on an operational way. In Croatia, we have also an interesting experience with the European ESRI guide. And you can see that when they started, they were almost 25% of examinations which were not appropriate. And 1 year later, they went to almost 90%, a significant increase of appropriate tests, while at the same moment, you have a decrease of the yellow and red line representing non-appropriate tests. So the point here is that CDS technology should be considered as efficient in increasing appropriateness level, in decreasing volume, and finally in decreasing the patient dose. That it's also a safety tool. So in Europe we have the ESRI guide, which was built thanks to a contract between the European Society of Radiology and the American College of Radiology. We have made an Europeanization of the content of the American CDS, and as you can see here, we have reviewed 1,600 examinations. So at the end, and overall, they were 9% of discrepancies. But if you look in detail, you can see that for breast, urinary, MSK, chest, women, almost no discrepancy. And the most important discrepancies are for in the field of cardiac imaging. Why? Because in the US, they mostly use nuclear medicine tests, while in Europe, we are using mostly ultrasound. So the discrepancy were not on the principle of making a test, but just on the kind of test which were used. So we are overweight than CDS for increasing appropriateness. This approach made by Medicare and private insurers in the US under economical pressures. So they set up a system of pre-authorization. So if you wanted to request from MRI or CT, you had to ask before the authorization, and this authorization was given by a radiology benefit manager. This is RBM, this is the name. And the problem is that there is a lack of transparency because nobody knows exactly how they proceed, which guidelines they will be using, but they claimed that they could reduce the volume by 20 to 30%. So this is efficient, but not very, I would say, ethically speaking, not very acceptable because we don't know how they work. This experience in Israel is very interesting because they have set also a center for pre-authorization for CT and MRI, but they had 14 experienced board-certified radiologists for the staff, and they clearly used either the American College or the Royal College guidelines. And you can see, and you can see here the net effect on CT and also on MRI. So this shows that you can make a pre-authorization system. It works, providing this, I would say, there is a full transparency on the way. Another example also, which shows the effectiveness of order checking. I made a study in my institution where I was chair, and this was a retrospective with 2 blinded seniors which reviewed 100 CT scans of head, chest, abdomen, and musculoskeletal each. And here you have the appropriateness level of this indication. You can see that for head it was 87, disappointing. Chest, abdomen, 85, disappointing. But for musculoskeletal, 98%. Why this difference? Because in my department, there was a checking of each imaging request by senior certified radiology specialized in MSK imaging, and you can see here the net benefits. So it was not very comfortable to discuss with physicians about the indication, but at the end it has shown to be effective. So the lessons of all this example is that we have to go beyond regulation because regulation is not effective. Point number two, CDS is effective, pre-authorization is effective, and internal checking is also effective. So you have different tools if you want to increase appropriateness in your imaging department, and you can choose. Now for whom? The primary goal, this is for the physician requester. It's not for us. This is for the physician. And we have to think how to convince physicians to use these systems. This is also for the imaging team because we should be able to discuss with the physician requester when we disagree. So this guideline should be also mastered by the radiologist. This is, at least in Europe, for the regulatory body, just to show that the department and compliance with regulation, and also for health authority, because in Europe at least, and I think in the rest of the world also, there is a disconnection between the competent authorities which are regulating radiation protection and health authorities. And it's very important to reconnect these two worlds because at the end, the health authorities which are in charge of safety of healthcare. So I think that we should consider each time we want to make a project for developing whatever the system, CDS, checking the fertilization, we should have a plan accepted by the physicians and supported by an educational component. We should convince them, we should not force them, we should convince them, and we should have also the political support for health authorities, or at least in an hospital political support from the institution. This kind of project cannot be the project of a single imaging department. It should be the project of the whole institution. So just to remind you that the dissemination of guidelines and the development of implementation policies for ESR guideline is the action number one of the Safe Imaging Call for Action. It's probably the most important and challenging issue for us. With that, I would like to thank you.